Leonardo da Vinci, through his study of the human form, described symmetry as a key factor in beauty and noted that the ratio of thirds should be respected. The mask of beauty created by Marquardt was constructed from the triangles and pentagrams consisting of sides of golden ratio 1.618:1, sometimes called as the phi. Hallmark of a youthful face, termed as the triangle of youth, is represented by a base down triangle with the apex directed at the mentum. This heart-shaped face is seen in the age of 20s to 50s, but is ultimately replaced by the pyramid of aging when this triangle of youth flips. Blepharoplasty. The word blepharoplasty is derived from the Greek word blepharon, which means eyelid, and plesine, which means to form. It refers to the surgical excision of skin, orbicularis oculi, and fat. Differences exist in the anatomical features of the various ethnic groups. For example, among the Asiatic eyelids, there is presence of pretarsal descent of the preseptal pad of fat, fusion of the orbital septum with the levator aponeurosis below the tarsal plate, a shorter vertical dimension of the tarsal plate, and a lid crease that begins in the medial canthal area. Topographical variations exist between men and women. For example, an ideal female eyebrow has been described as resembling the wing of a gull. In women, the eyebrow lies 0.5 to 1 mm above the orbital rim and is arched with its apex between the lateral limbus and the lateral canthus. However, most men tend to have straighter eyebrows. Eyebrows serve as a foundation for the lids. The skin of the eyebrow is thick with a corresponding thick subcutaneous fibroadipose layer. The eyelids are complex specialized facial adaptations designed to protect, moisten, clean the ocular surface. The upper eyelid crease results from the superficial insertion of the levator fibers. The crease lies about 8 to 11 mm above the central lid margin. The distance between the skin crease and the upper eyelid margin is termed the tarsal platform. Ideally, the ratio of the tarsal platform to the distance between the upper lid crease and the brow should be the golden ratio or the phi. The upper lid has medial and a central fat pad. The medial fat pad lies medial to the levator aponeurosis and is separated by a weak septum from the central fat pad. The central fat pad sits on the levator aponeurosis encased in a thin membranous sac. The orbital lobe of the lacrimal gland lies laterally and being posterior to the septum can be mistaken for the preaponeurotic pad of fat, removal of which must be avoided. The indications for blepharoplasty include functional and cosmetic. The functional indications are dermatochalasis, which refers to a laxity or redundancy of the eyelid skin and muscle due to loss of elastic tissues, thinning of the epidermis, weakening of the connective tissue in the eyelids, and mechanical forces such as rubbing and aging. Blepharochalasis. Steatoblepharon is the prominence of eyelid fat pads and applies to the upper and the lower eyelids. It may be associated with the weakening of the orbital septum and the overlying orbicularis oculi muscle and the skin. Quintessential in the run-up for blepharoplasty is a comprehensive preoperative evaluation which involves assessment of the quality, quantity and relative symmetry of the redundant skin, assessment of the brow position, the presence of fat pad herniation and grading of the medial and the central preaponeurotic fat herniation, evaluation for a possible lacrimal gland prolapse, presence of any concurrent ptosis, lack of thalamus, presence of an intact Bell's phenomena, and assessment of the orbicularis strength, assessment of visual acuity, pupillary examination, ocular motility, intraocular pressure, examination of the anterior segment, and finally the fundus exam. The single most important aspect of blepharoplasty is the marking. If the lid creases are symmetric, they are considered as the base of the incision. The marking of the lower incision in blepharoplasty involves placement of the 4 dots as follows. Point A is placed at 5 to 7 mm above the medial commissure. Point B is placed 9 to 11 mm in the midpupillary plane. This also correlates with the superior edge of the tarsus and the lowest position of the eyelid fat below the orbital septum. Point C is placed laterally 8 to 10 mm above the lateral canthal angle, and point D is marked at 12 to 15 mm from the lateral commissure, directed superolaterally towards the lateral orbital rim. One of the common techniques followed in blepharoplasty is the pinch technique. It involves the use of a pair of smooth forceps to grasp the excess skin above the lid crease incision just until the eyelashes begin to rotate upwards. This is marked as the maximum amount of skin that can be safely removed. For a clear margin of safety, after having established the tarsal platform show, superior border of the incision should pass no closer than 1 cm from the inferior border of the brow. The varied types of skin incision in upper eyelid blepharoplasty include classic crease incision associated with more chances of a temporal brow droop, scalpel-shaped incision which negates the extra brow droop, and third is the Belin-Beers incision which goes beyond the temporal brow margin for counteracting the lateral hooding. Surgical technique in blepharoplasty involves making the skin incision with the tip of a monopolar radiofrequency probe. Skin flap is then raised from the underlying orbicularis oculi muscle to expose the muscle bed. Following this, fulguration of the retroorbicularis pad of fat is done. Orbicularis is closed with 6-0 vicryl interrupted sutures. The skin wound is then closed with 6-0 proline sutures in a horizontal mattress fashion. Here are a few examples of patients who have undergone upper eyelid blepharoplasty with good functional and cosmetic outcomes. In a nutshell, blepharoplasty is the most common facial aesthetic surgery. To attain an optimal result, care and attention must be given to patient selection, expectations, preoperative evaluation, surgical technique, and postoperative care.